Welcome to eNormous Nephrology. This is an attempt on my part to make nephrology exciting for everybody and to prepare upcoming physicians to enter the field of nephrology or utilize nephrology to the best of their abilities in their practices, whichever field they may be in. So I started off with an intention to do an 8 series of board review sessions so that it would be a quick introduction to nephrology, and then it will be followed by individual 20-minute short sessions on particular exciting topics in nephrology or based upon requests from viewers. So we have gone through 5 sessions of board review already, and we've covered physiology, electrolytes, acid base, things like that. Now it's time to jump into glomerulonephritis. And so this session will be a quick introduction to pathology and a quick kind of immersion into how glomerulonephritis looks and feels like in the clinical arena. And then the subsequent 4 sessions will go into individual glomerulonephritides in more detail. So this is volume 5 of 8, and the goal is to prioritize areas needing further study as you progress towards the boards. So what is glomerulonephritis? Basically, it's glomerulus plus nephritis. So it's a disease process involving the glomerulus, and it's inflammatory, which hence the itis, which implies inflammation. And this, when we usually talk about glomerulonephritis, we're usually implying an autoimmune etiology, although the inflammation can be from any cause other than autoimmune as well. Next slide. Non-autoimmune causes would include vascular causes like arterial or cholesterol emboli, as in after a cardiac cath where manipulation has liberated some emboli, particularly to the vascular system of the kidney. And then acquired polyarthritis nodosa, although polyarthritis nodosa obviously can also be autoimmune. Thrombotic microangiopathy, which can occur with hypertensive emergencies, but it can also be autoimmune, as in with antibodies to ADAMTS13. So vascular causes can be autoimmune or non-autoimmune. Antiphospholipid antibodies, for example, is an autoimmune phenomenon that can cause vascular pathology, but can also cause kidney involvement, such as FSGS, membranous, or even minimal change, and we'll discuss these in individual sessions later on. Cancers are inflammatory, so diabetes is the most common cause of inflammation in the kidney, so to say, and hypertension also is an inflammatory process. So when do you suspect glomerulonephritis? When do you suspect that something autoimmune is going on? So usually you see a combination of proteinuria and microscopic hematuria. And when you see that combination, then a red flag should go up that this could be a nephritic process. If you don't have microscopic hematuria and you have a lot of proteinuria, typically greater than 3.5 grams, that's also a glomerulonephritic process. That's a nephrotic process. So typically you will do urine microscopy to see if there's a hint of glomerulonephritis in a particular clinical scenario. And in the urine sediment, typically you want to see hematuria, and we'll talk about dysmorphic red blood cells in just a second. If you see pyuria without infection, so it's typically called sterile pyuria, you want to think about interstitial nephritis. Red blood cell casts are typically seen in nephritic processes, and white blood cell casts can usually imply interstitial nephritis. So what does the red blood cell look like under the microscope in the urine? Basically, they are small, round, with a concave shape with this typical appearance. Next slide. And those red blood cells, when they coalesce in the tubules, after going through the glomerulus, the glomerular basement membrane, will look basically in the shape of a tubule, and this is a typical red blood cell cast. White blood cells are a little bit larger. They're about 1.5 to 2 times larger than the red blood cells. They are round and usually colorless, and you can actually see a few grains inside, kind of a grainy appearance, and that's a typical white blood cell. And the white blood cells, when they coalesce inside a tubule, will form casts with this appearance, where you can see kind of individual white cells within the cast, much larger than a red blood cell. So what's a dysmorphic red blood cell? So you have isomorphic red blood cells and you have dysmorphic red blood cells. So isomorphic implies that the shape of the red blood cell is preserved, typically round and unaltered. Dysmorphic implies that it has gone through the glomerular basement membrane and that its shape has changed. So for example, all these would be considered dysmorphic. This one, for example, looks very altered. This one looks altered. Many of these would be considered altered. This one kind of looks isomorphic. This one looks a little bit dysmorphic. So there are dysmorphic red blood cells. Now the question is this renal hematuria or is this glomerulonephritis? How do you distinguish? Next slide. So, like I said, dysmorphic red blood cells implies that they're cremated or misshapen. But just because you see dysmorphic red blood cells does not mean that something autoimmune is going on, or that the glomerular basement membrane is somewhat involved in an inflammatory or autoimmune process. So if you see red blood cells with vesicle-shaped protrusions, those types of dysmorphic red blood cells are the most predictive of glomerular disease. For example, in one study, the presence of acanthocytes, meaning ring-shaped RBCs with vesicle-shaped protrusions, had a sensitivity of 52% for glomerular disease and a sensitivity of almost 98%. So glomerulonephritis, you frequently hear the term rapidly progressive glomerulonephritis, and that's when we all get really excited. That implies rapid decline in renal function, and by rapid decline we mean weeks to months. And there's usually a decrease in GFR 50% or more over weeks to months. And usually if you do a kidney biopsy in that setting, you would expect to see crescents. And a crescent basically is a glomerular epithelial cell proliferation due to leakage of fibrin and inflammatory cell mediators into the Bowman's capsule. So the glomerular basement membrane is injured, and fibrin and inflammatory cells will leak through the glomerular basement membrane into the Bowman's capsule. And that's where you see the crescent. So frequently, if the acute phase of glomerulonephritis is pretty much kind of burnt out or treated fully, and then you just have kind of a smoldering phase of glomerulonephritis, you'll see a slow decline in renal function over months to years. This is chronic glomerulonephritis. In this case, the initial immunological injury has resolved, and the urine sediment is no longer active. So this is kind of, at this stage would be chronic kidney disease, and you would manage it as just a chronic kidney disease. You can have acute glomerulonephritis. So this is acute kidney injury with rapidly increasing azotemia over a period of days. The most common cause of acute glomerulonephritis is post-infectious. This usually presents like typical acute kidney injury, decreased urine output, and patient is hypertensive because of the acute kidney injury. Patient has edema, proteinuria, and RBC casts. So we'll quickly go through the differential of things that we should keep in our mind, because when you talk to the patient, you have to know what you're asking about, what you're thinking about. And if you think about all of these things in the back of your mind, you'll ask all the right questions, and the path towards diagnostic decision making becomes straightforward, and also you will not miss anything, and there won't be any glossovers. So the most common way to think about glomerulonephritis is to categorize them into three things. In antiglomerular basement membrane disease, and this is in which you have linear staining of the glomerular basement membrane because of antibodies that bind to the glomerular basement membrane. And then you have immune complexes, and this is where immune complexes form because of antibodies to certain antigens. In lupus, it would be antinuclear antibodies. In IgA, it would be an abnormal form of IgA. And then there are other antigens in post-infectious and peri-infectious glomerulonephritis. And then membranoproliferative glomerulonephritis is a whole topic in and of itself. And here you can it can be due to monoclonal gammopathy, it can be due to lupus, it can be due to immune complexes, it can be due to infections, or it can be due to a deposition of C3. And then the last category to think about is Pauciimmune. And in this case, there are no immune complexes. And we shouldn't say no, because anytime you say no or never, you're going to be wrong. But the most appropriate way to put it would be minimal. So you may have a very few immune complexes. And that's what Pauciimmune implies, is minimal immune complex deposition. And here, we're mainly thinking about granulomatous polyangiitis, previously known as Wegener's, but nobody calls it Wegener's anymore, or microscopic polyarthritis. And then Church-Strauss is rarely seen, and that's where you have eosinophilia, asthma, and then certain organs are affected, including the kidney, lungs, and skin, etc. So what should you ask? What kind of questions are appropriate in the glomerulonephritis scenario when you're thinking about possible autoimmune involvement? First thing probably that comes to mind is dark or Coca-Cola colored urine, because it implies hematuria. Decreased urine output. Has your urine output decreased of late? Fevers, malaise, edema. These are non-specific questions, but important questions, because they're very common in the glomerulonephritis scenario. Of course, I should always ask about hemoptysis, because it's Goodpastures would be easy to rule out, and also important to consider, because the treatment is effective. And lack of treatment is very detrimental. So you should always rule out lupus. So you would ask them, do they have a mallorash? And of course, you would be looking at them while you speak to them. So you would note whether they have a mallorash or not. Discoid lesions, if they, whether they have skin lesions, whether they have oral ulcers, light sensitivity, photosensitivity, and then confusion would be important. Not only will you get history from maybe family, about confusion, but you can actually ask them, do you ever get confused? Do you ever not know where you are or who you are or who you're talking to? Things like that. Seizures. Serositis is important. And when you think about serotitis, you're mainly thinking about the pleural area. You're thinking about the peritoneal area. So you're thinking about pleural effusions and ascites. Arthritis, of course, specifically hand arthritis and other joints as well. And Raynaud's syndrome, which would be abnormal blanching or color changes of the digits. Of course, you should always rule out infection-associated glomerulonephritis. Have they had pharyngitis? Do they have other infections? Typically, valvular disease, endocarditis. Have they had IV drugs? Have they had a valve replacement? And then, of course, you should always rule out skin, foot infection, visceral abscesses, hepatitis, and travel history. Dense deposit disease is very rare, but you should ask them about non-specific symptoms like fatigue, pallor. And then drusen is an ophthalmologic finding, which you might see mentioned in the record. That would be extracellular deposits of lipids, proteins, and cellular debris which are found within the layers of the retina. And they appear as small yellow deposits on dilated eye fundoscopic examination. Other things to think about would be fat atrophy affecting the upper limbs, trunk, and face, and then non-specific things like hypertension. Cryoglobulinemia implies that you have antibodies which are sensitive to temperature and which precipitate with lower temperatures, and this would cause Raynaud's syndrome, digital ulceration, livedo reticularis, which is a specific appearance on the skin, purpura, basically hemorrhages in the skin, arthralgias, and peripheral neuropathy, and rash, which would be basically a form of cutaneous vasculitis. And then Pauciimmune glomerulonephritis, you're thinking about sinusitis, hemoptysis, pulmonary infiltrates. And you should always keep in mind, are they doing cocaine? Because in the past, and probably also in the present, cocaine used to be contaminated with levamisole, which can cause ANCA vasculitis. Next slide. So the initial workup for glomerulonephritis is always, starts with complements, of course, and we'll talk about what complements, what kind of patterns you would be looking for. Anti-nuclear antibodies are very commonly ordered. So how much dilution do you need of anti-nuclear antibodies in order for you to have a high suspicion of lupus in your patient? Should be greater than 1 to 160. And then in terms of kidney involvement of lupus, you want to see double-stranded DNA. So hepatitis panel should always be ordered. Anti-neutrophil cytoplasmic antibodies. And typically you can order ANCA non-specifically, or you can actually specifically check for MPO and PR3. And these days, it's actually recommended that you order the MPO PR3 directly instead of the non-specific ANCA test. So complements. How do you interpret complements? With an inflammatory autoimmune process, you're either going to involve the classic complement pathway or the alternate complement pathway, and that will determine which complement is consumed. In the classic complement pathway, both the low C3 and the C4 will be low. In the alternate pathway, only the C3 will be low and the C4 will be normal. When will the C4 be normal? C4 will be low. The typical scenario in which the C4 is low is cryoglobulinemia, because C4 is cryoprecipitable. So this is typically something that we keep in mind. If you have both low C3 and low C4, you're thinking about lupus, peri-infectious. Those are the two most common scenarios you're thinking about. If your C3 is low, then MPGN and post-infectious should be in the back of your mind. And then, as I said, if the C4 is low, you should definitely be thinking about cryoglobulinemia. So let's talk about pathology. Pathology, a lot of people are afraid of it, but it's actually not that difficult. When you read the pathology report, you're going to see all of these terms. Focal implies that less than 50% of the glomerulus is inflamed. And we'll talk about what does inflammation mean actually. Diffuse implies greater than 50% inflammation. Segmental means that only part of the glomerular tuft is involved. And global means all of the glomerulus is involved. Mesangial hypercellularity implies that there's greater than 4 nuclei in a contiguous matrix of a mesangial segment. And we're going to see examples of this, how to see if there's mesangial hypercellularity or not. When we talk about inflammation, we're talking about mesangial hypercellularity, or we're talking about endocapillary hypercellularity. And endocapillary hypercellularity implies that the cell aggregates are filling the capillary lumen. So obviously, if the capillary lumen is full of cells, then you can't see the capillary lumen. And that's very typical on pathology findings, and we'll see an example of that. Membranoproliferative, as the word implies, you have the glomerular basement membrane involved, and there's proliferation, whether it's mesangial hypercellularity or endocapillary hypercellularity. And typically, the glomerular basement membrane is damaged so that the cell starts to make a new glomerular basement membrane. And so you're going to see a tram track, because you're going to see the old glomerular basement membrane and the new glomerular basement membrane, almost like a tram track. And that's very typical of MPGN. And crescent, as we talked about, is extracapillary hypercellularity, because the glomerular basement membrane is damaged and fibrin and cells will leak through the glomerular basement membrane into the Bowman's capsule. Stains can be important to know, because if you know what kind of stain it is, you know what to look for on that particular slide. The periodic acid shift is mainly used to look at the glomerular basement membrane thickness, the mesangium, and the number of glomeruli. The Jones-Methenamine stain, or silver stain, is mainly used to look at irregular contours, spikes, and glomerular basement membrane thickness. The trichrome is used to judge interstitial fibrosis and interstitial edema. Sometimes you might see red granules. That's less common. But trichrome is usually very useful to know how much fibrosis there is. And the hematoxylin and eosin stain gives you cellular detail. So it's somewhat nonspecific. And then for amyloid, you have a special stain, the Congo red. Here's a normal glomerulus. You can see that. So the mesangium is the kind of purple stained regions, and you can see here there are two. Here there are two, not greater than 4, which would imply mesangial hypercellularity. And the white areas, those are the capillary loops, and you do see the capillary loop, so there's not any endocapillary hypercellularity in this particular glomerulus. This is a periodic acid shift stain. You can see that the glomerular basement membranes are nice and thin, and not many cells in the mesangial area, and the capillary loops are nice and open. This is an example of mesangial hypercellularity. Here you can see that there are at least 5 cells. When you see at least one area of the mesangium in which there are more than 4 cells, that's enough to diagnose mesangial hypercellularity. And even here there are 4 cells. So this is an example of mesangial hypercellularity. This was a case of IgA nephropathy. Here you can see that all the capillary loops are not really visible. So this is an obvious case of diffuse proliferation or endocapillary proliferation. This is actually very typical of lupus. All the immune complexes are giving a wire loop type appearance, and wire loops are pathognomonic for lupus. I just put that in there because it's so classic that they probably will find it a good good thing to test on. This is a silver stain, very a nice way to look at the basement membranes. And here you can see tram tracks. So you can see basically what looks like tram tracks as a train would travel on a tram track. And this is because the original basement membrane is damaged, so the cell makes a second glomerular basement membrane, and you see the tram tracking appearances. This is a typical crescent. Here's your Bowman capsule, nice and open, and here you can see that cells and fibrin have broken through the glomerular basement membrane into the Bowman's capsule. So this is a nice classic crescent. So this is electron microscopy. So here, this is a subepithelial hump, and this is classic for post-struct. This is subepithelial, mainly because you can see that there are some podocytes here, and it's basically right underneath the podocytes, and that's classic for subepithelial humps. Next slide. Here you can see that the podocytes over here, and this is subendothelial. So these are subendothelial humps. Subepithelial humps are mainly classic for only a few things, like membranous nephropathy. Subendothelial immune complexes can be seen in many things, typically lupus and other many processes. You will see subendothelial humps. Subendothelial immune complexes. These are just patterns that you should keep in mind. Glomerulonephritis, of course, in light microscopy, you're going to see crescents. On immunofluorescence, you're going to see a linear staining of IgG on the glomerular basement membrane. And on electron microscopy, you probably won't see much. Lupus, the classic thing we should remember is full house. And by full house, we mean that you're going to see staining for IgG, IgA, IgM, C3, and C1q. So all of them will light up on immunofluorescence. On light microscopy, classic findings would be wire loops, hematoxylin bodies are somewhat rare, and then endocapillary proliferation. On the electron microscopy, you're going to see subendothelial deposits. If you have lupus, can have a membranous appearance, and that would be a class 5 lupus. And there you will see some subepithelial immune complexes. And then actually there's a classic finding called the tubular-reticular inclusion, which I will show when I do an actual talk on lupus. So medications, typically like hydralazine, can cause drug-induced lupus, and these may actually have serological markers detectable like p-ANCA, anti-lactoferrin, anti-elastasin, anti-double-stranded DNA. Here you're going to see necrotizing GN, that implies cell death, cell debris, fibrin, inflammation, things like that. So you're going to see all of that, fibrin and cellular inflammation, cellular conglomerates and things like that. You may not see much immune complex on the immunofluorescence or immune complex deposits on electron microscopy. And then in infection-related GN, this will be exudative. So you'll typically see neutrophils, macrophages, mesangial and endothelial cells. And then again, you'll see endocapillary proliferation. If it's classic post-infectious GN, you're going to see granular IgG, IgM, and C3. And then in staphylococcal or other peri-infectious, you're going to see IgA and C3. C3 glomerulonephritis implies that you have mainly staining of C3 on immunofluorescence and pretty much nothing else. And C3 glomerulonephropathies would be dense deposit disease, as we saw, which is basically a dense deposit in the basement membrane. And then in C3 GN, you can see subendothelial, mesangial, or even subepithelial deposits. So you can have, and then on light microscopy, you can have a mesangial-proliferative MPGN, endocapillary, or crescentic appearance. Membranoproliferative glomerulonephritis. Here, again, you're going to see involvement of the glomerular basement membrane, and you're going to have proliferation. So double contours, which would be a tram track appearance, implies damage to the glomerular basement membrane. You're going to see endocapillary proliferation, and mesangial interposition implies that you have cells within the mesangium. MPGN can be idiopathic, so you can have a secondary cause of MPGN, or you can have idiopathic MPGN. And then idiopathic MPGN, you're going to see C3, IgG, IgM deposition. Hepatitis is a common cause of MPGN, and here you're going to see IgM and C3. And then the other things that you can see that are other causes of MPGN, remember that biopsy is not a disease. It's a pattern that we see. So we stained the kidney tissue, and we see patterns. So it's not a disease, it just gives us patterns. And those patterns are seen in disease processes. So we kind of make that leap, a leap of faith almost, that this pattern is showing us manifestations of this disease process. It can be without cause or cause that we don't know yet, and that idiopathic cause eventually may reveal another cause that we haven't associated as of yet. Hepatitis is a common cause of an MPGN appearance. Monoclonal gammopathy is a common cause of the MPGN appearance. And here you're going to see staining for either kappa or lambda, but not both. And then lupus is actually a common cause of MPGN. And here in the immunofluorescence, of course, you're going to expect a full house staining if lupus is indeed the reason for the MPGN appearance. So on the electron microscopy, you'll have subendothelial deposits, mesangial deposits, mesangial interposition, again, new basement membrane formation, and podocyte effacement. Pauciimmune glomerulonephritis. So here, the most important thing is that the immunofluorescence is negative or near negative. Electron microscopy, all you're going to see is fibrin, and then in the light microscopy, you're going to see necrotizing granulomas. And typically, you're going to see crescents, unless it's not active ANCA-vasculitis. IgA nephropathy typically means that the IgA is the main staining appearance of the immunofluorescence. You may also have C3 deposition. And then in the light microscopy, you're going to have mesangial proliferation. You can have focal proliferative pattern as well. And IgA, in some cases, can be crescentic. And obviously, that requires more intense immunosuppression. And you can see endocapillary proliferation. But when you think IgA nephropathy, you should think mesangial proliferative. And again, on electron microscopy, you're going to see paramesangial deposits, but other deposits are possible, but not typical. Thrombotic microangiopathy implies platelet plugs, because you have microangiopathic hemolytic anemia with damage to the blood vessel wall. So you're going to see fibrin thrombi, you're going to see platelet plugs. Again, you're going to see double contour. So double contour only means a few things. When you see double contour or the slit appearance of the basement membrane, you want to think MPGN, you want to think thrombotic microangiopathy, or you want to think transplant glomerulopathy, which is basically chronic antibody-mediated damage to the allograft, kidney allograft. So you're not going to see immune complex deposits. And on the electron microscopy, basically you'll see fibrin and new basement membrane formation, which implies the same thing as the double contour appearance. Hypertensive emergency can give you a TMA appearance, and that's actually very common. We'll finish off with a question. The question is, it's actually not easy at all. It's only meant to stimulate thinking, I always like to make you think about things and find something interesting within mundane processes. So this is designed to do that. It's not designed to be a test. It's not designed to be a gauge of your knowledge. You're evaluating a 19-year-old man with increased creatinine of 1.9 milligram per deciliter, hematuria and proteinuria of 1.2 grams per day. He describes a flu-like syndrome about 6 weeks ago. His grandfather died of end-stage renal disease, and he has 2 cousins, both living in Greece, who have undergone kidney transplantation. Tests for hepatitis are negative. ANCA, ANA, rheumatoid factor, and double-stranded DNA are all negative. C3 is mildly low. Biopsy demonstrates a diffuse proliferative pattern. Immunofluorescence reveals both C3 and IgG deposition. Which one of the following statements is most correct? Although exceptions may occur, immunofluorescence microscopy generally shows both IgG and C3 deposits in post-infectious GN, but not C3 GN. Although exceptions may occur, immunofluorescence microscopy generally shows both IgG and C3 deposits in C3 GN, but not post-infectious GN. And light microscopy can distinguish between C3 GN and post-infectious GN. Or D, genetic screen would be of little utility in distinguishing post-infectious from C3 GN. Next slide. So things to think about here is that C3 GN is typically MPGN. It's membranoproliferative. But other processes can occur. Mesangial proliferative endocapillary or diffuse proliferative GN can be present. So it's just because it's not MPGN doesn't mean that it's not C3 GN. And as most of us know, C3 GN can be acquired or genetic, but actually acquired autoantibodies are much more common than mutations or genetic rearrangements. And post-infectious GN, those typically show a diffuse proliferative GN. As far as immunofluorescence is concerned, C3 GN, the C3 will be twice as intense, and IgG staining is scant or absent. In post-infectious GN, you have staining for C3 and IgG, but sometimes the C3 may be more intense. So just because you have relative intensities of C3 versus IgG, you can't necessarily distinguish between C3 GN and post-infectious GN that way. Post-infectious GN resolves within 8 weeks. So if after 8 weeks you still have renal dysfunction, proteinuria, hematuria, and hypocomplementemia, then you should think about C3 GN. Next slide. A 27-year-old man who is a cigarette smoker presents with pulmonary renal syndrome. A kidney biopsy shows a diffuse crescentic GN with linear deposits of IgG and C3 on immunostaining. Regarding the serologic assessment of anti-GBM disease, which of the following statements is most correct? The detection of circulating anti-GBM antibodies is essential for diagnosis. The detection of ANCA does not influence treatment or outcome. Antibodies to laminin 521 are found more frequently in patients with lung hemorrhage. Peroxidase antibodies are found more frequently in patients with severe kidney disease, or anti-GBM antibodies are detected in up to 5% of patients with SLE. Next slide. So, glomerular basement membrane is lamellar and quaternary. So it has type 4 collagen, it has laminin, and it has peroxidase. And typically, anti-GBM disease has antibodies to type 4 collagen. But you can have anti-GBM disease because of antibodies to laminin, and these antibodies are present in pemphigus, cutaneous lupus, and autoimmune pancreatitis. In one study, 33 out of 101 patients had antibodies to laminin 521, and these patients frequently had lung hemorrhage. Peroxidase is important because it gives the glomerular basement membrane its quaternary structure, and this antigen is actually homologous to MPO, and so there are cases in which you have anti-GBM and ANCA positivity, and this double positivity is now thought to be because of peroxidase presence in the glomerular basement membrane, and variable outcomes have been reported. So in one report of 20 patients, you had no antibodies to type 4 collagen. You did not have diffuse crescentic GN. You did not have lung hemorrhage. And all you saw was mild proliferative GN on light microscopy, and outcomes were better than expected. But you had the classic linear IgG staining. In another case series of 60 Chinese patients, you had the linear IgG staining, but no circulating antibody. And in 42%, you had crescentic GN, and 5% had lung hemorrhage. So clearly, somewhat uncharacteristic. And then there was one case report of florid anti-GBM disease with kappa light chain restriction, circulating paraproteins, suggesting a monoclonal gammopathy of renal significance spectrum. So to keep in mind is that currently conventional techniques may not be able to measure low levels of circulating anti-GBM antibodies, and better, highly sensitive biosensor assays may be needed. So that's it for a quick introduction to glomerulonephritis. The next session, the 6th session of the 8 sessions of board review, will start dealing with lupus and other common diseases yet to be determined. See you next time.